Okay, we have a pediatric audience here. I'm going to ask a couple questions in the beginning. Who are those two people on the screen? Anyone have any idea? Hint, look at the red color. Think of universities that are associated with red. Think of your dental history. I feel like that guy in Ferris Bueller's Day Off. Bueller. Okay, anyone, anybody. All right, this is Doctors Hayden and Harris, okay? Hayden's on the left, Harris is on the right. Does that ring a bell? No. They founded the first dental school in the world, which is University of Maryland in Baltimore. In the world, first in the world. And I used to practice at the closest location to the original spot of the school. There's a plaque downtown in Baltimore near Baltimore and Light Streets. And do you want to allow the following program for them? We don't want to do that, do we? Make a change. Okay, so we want to say, I don't think we want to do that, do we? No. Okay. Maybe that's Dr. Hayden and Harris coming back. But anyway, I used to practice very close to there. So if you ever get to Baltimore, you can go down to the Charles Center Plaza and look at the plaque. But at any rate, it is the first dental school in the world. And we're going to talk today because we are trying to stay in dentistry on the leading edge. So it was first then. We're trying to stay on the leading edge. Since this is a pediatric dentistry audience, I'm going to do a little quiz here. Who knows who Dr. Doofenshmirtz is? Anybody? Dr. Doofenshmirtz? Okay. You're in the tri-state area. Who said that? Phineas and Ferb. There you go. Yeah, that's it. So I can't believe you guys work with kids. And Phineas and Ferb, so the evil guy in the tri-state area is Dr. Doofenshmirtz. It's a cartoon. Come on. You guys work too hard, okay? All right, and I have another question. Okay, who saw Hangover? Mr. Chong, the guy, or the Asian gentleman that jumped out of the trunk. He's a licensed physician. Yeah, you know that. Okay, that's good. That's good. You're aware of that. You're not just in the books all the time. He was on a plane, and a person passed out, and they called for a physician to help. And he came over and he said, "They said you can't touch me. You're Mr. Chow. You're not a doctor. Get out of here." But he is a doctor, really. He's licensed and can practice. So, a few little known, but maybe interesting facts. Okay. So I want to go back here. I have two hats I'm wearing here. The first hat is the Senior Director of Research and Laboratories for the ADA, your American Dental Association, and I bring you greetings from hopefully your American Dental Association. You're all members or intending to become members. If you aren't, you have to leave right now. No. So anyway, and I'm also chair of the American Dental Association Standards Committee for Dental Informatics, which we'll talk a little bit more about in this presentation. So I'm mostly wearing that second hat, but I want to give you a little ad for our laboratories. This is what we do in the lab. Professional product review. You may have seen that. It was a written publication that accompanied the JADA quarterly. It's now a digital publication. We do seal of acceptance testing, so everybody knows seal of acceptance. 9 out of 10 dentists, that's what they associate it with, but it's actually products approved over the counter for patient use. We look at critical and emerging issues. These would be things like bisphenol A in restorations, mercury, overheating of electric handpieces, why that happens, is it a danger? We look at occupational safety and public health. And we do standards. So we don't only do informatics standards, we do product standards. We have a corresponding ADA Standards Committee for Dental Products, and they're active in the same way with other groups. They liaison with other groups, and they work internationally in a very parallel manner to the Standards Committee for Dental Informatics. So in our lab, we do bench activity, and we do look at methods and methodology. We have subject matter expertise. When we look at standards, we look for gaps, ways to improve testing. We participate in interlaboratory round-robin testing, so we can validate that a standard actually works in different laboratories. And we also, where we can't do things in the lab, we actually collaborate. So we'll form partnerships with groups that can do clinical collaborations or that offer subject matter expertise that we do not have in our lab, or methods or instrumentation. So we have a number of collaborations going on right now. Here's what the PPR looks like. It's also pushed out to members digitally. Dave Surratt, Dean at VCU and Vice President, I think, of Research for VCU in Richmond, is our editor, and it's a publication of the Council on Scientific Affairs. Welcome to go to ada.org/PPR and look it up. We try to be unbiased, scientifically sound, clinically relevant, reader-friendly, timely, and concise. So there's my advertisement for the ADA PPR. We also have executive summaries now in JADA. In JADA, you will see part of the PPR issue. You will see the Dr. Glick, who is the editor of JADA. Some of you may know him. So Dr. Glick wants us only to put articles that generate new data from PPR or that are systematic reviews. In other words, if it could be the world's foremost expert on something, if you write it like a book chapter or a one-person article, it's an opinion piece. So they're not looking for opinion pieces in JADA. JADA now rejects 85% of what's submitted. So we have our executive summary and then point people to our full issue, which has larger number of articles and topics. We're also doing the Professional Product Forum at the annual session, which will be right on the convention floor. We're having a booth there where we will do point-of-service screenings. We'll do finger stick testing, which you've done at Columbia here. I know there was a study going on to look at the value of doing this type of testing in the dental office, these medical screenings. What's the overall benefit, direct and indirect costs, as well as intangibles. So direct cost would be, what does it cost to do it? Indirect, you could say, what do we avoid? Or in other words, what are the problems we're avoiding down the road by intercepting initial diabetes cases, pre-diabetic cases, and then not allowing them to progress. Then the third thing is intangible, that's pain and suffering and things like that are avoided. At the VA, when I was at the Department of Veterans Affairs for many years, this is a little bit of humor, but in a sort of a dark humor way. We would say, because of all the diabetic patients we had, as time went on, we were doing more and more on less and less of our patients. So we don't want to get to the point where people are losing limbs and they're losing appendages and they're going blind and so forth, when we can screen this early, and we think we can prove ultimately it's a benefit to society to do it that way. So when we do these things at the ADA, we do them for members, the profession, and the public, and the scientific community in general. Here are some of the current and upcoming topics we have for PPR. And we can also, I would recommend you go to the ADA website. This is like, you ever heard of the Sports Illustrated curse? Where if you're on the cover, you have a bad season or you get hurt. So this is Hank, our machinist from the lab. Right after this appeared on the cover page of ADA, he had a very bad infection, and he's been out of work for like 5 months now. But he's coming back, so it has a happy ending. But he was in intensive care for a long time. We are contending it was due to the curse. So beware if you're ever on the cover of JADA or the opening page. All right. Now, pediatric audience, I have to put in some, sort of pandering pictures of children, cute pictures. I could have put puppies in there or something, but I'm putting, so you can see I'm from Baltimore. These are Ravens fans. Those are two of my grandchildren, Harper and Augie, getting ready for the Super Bowl. This is one of my other grandchildren. He's actually ready for the next Superman movie, which is coming out soon. So he's ready to go. And then I was a child once. That's me as a child. I was a child. I can relate to children, okay? Believe it or not, one of my kids found that at our house and texted to me. So I said, I'll put it in there. So it's hard to believe that I could, looked like that at one time. All right, let's get to the discussion. Health information technology is electronic health records. It's standards and certification, implementation, and I mean real-world implementation, frontline, end user, provider implementation, data aggregation and analysis, and then we're going to talk about accountable care organizations, quality indicators, and outcomes. Really, ACOs are about outcomes. Now, what is HIT? It really boils down to this in my mind. It's the use of computing and communication technologies applied to support healthcare. So can they be drivers? Yes, usually they're enablers. Can they set the boundaries and the direction you want to go by the fact that they can box you in? Yes. Should they? Probably not in many instances, but you'll see that that distinction is blurring between HIT as a driver and an enabler, becoming more of a driver a little bit. What's an EHR? So an EHR is a compilation of digital data, hopefully over a lifetime. So as your patients start out, they're going to, if you get all their data in there, and it can be aggregated and become a virtual lifetime electronic record, also known as VELR. And by the way, we do like to TIA in the standards world. That's talking acronyms. Sometimes we even CIA. That's communicate in acronyms. So anyway, you will see some abbreviations. If they don't make sense, stop me, you know, if you care. I'm sure you should care. So the dental, this is all organized around a unique patient. So what does that mean? You've got to have patient identifiers. As you know, the Congress had said we were going to have unique patient identifiers in the United States, but then they backed off because of various concerns. Some were around security and privacy. This would make it difficult in a certain way for someone to use someone else's card to get services, for instance, their insurance card or their payer card. So what is the dental EHR in particular? It's a set of modules, and they function together to form a unified dental record. These are some of the modules. We're going to comment a little bit quickly later on charting. I don't believe in the electronic health record you want to be mimicking what we do in paper. And many times we're not out of that mindset and we don't understand the capabilities of the media, ways to use imaging, ways to use decision support, ways to bring resources to bear, ways to reach out to patients outside of the office for joint decision making. So those types of things, in addition to coordination of care, which is another issue, but the charting, we do not want to duplicate what is done in currently, because think of a dental chart for caries. You deal with those all the time. It's basically we're trying to draw a representation of the mouth and recreate it, and it gets a little more complicated even in the digital format, because in pencil and paper or ink, you can kind of draw in if it's halfway down the mesiobuccal cusp or something like that. It's harder to indicate that in electronic odontograms. So you really probably should use an image and be able to annotate something to the image and follow that over time. Sorting of images offers a great potential that has not been realized yet, to look at something like, what has tooth number 3 had? Give me every x-ray with tooth number 3 that's in, or any visible light image. Remember, as we go through this, if you have to walk away with a few pearls here, this is one of them. When you're considering electronic health records, think of items. So what data elements are you capturing? What's the workflow for capturing them? It should be in the clinician's workflow. How do you display or represent these, the data that you have? How do you recombine it to display it in the program in a useful way? And then how do you aggregate it? How do you share it? How do you exchange it, including the term semantic interoperability, which we'll talk about later, and then integration, and then the analytic part of it. So the big data, ultimately, but certainly if you wanted to analyze your own practice, you'd need an analytic package that sits over a relational database instead of doing Excel reports, or in the case of Axiom, Crystal reports, which are very difficult to work with for the average person, particularly Crystal reports. So you have to go to your IT department to give you a report, and it's not what you want, and they say, well, it's what you explained to me. It's a classic back and forth with IT. Let you have the data, give you a smooth working, intuitive analytic package so you can mine it. You can figure out an awful lot of things about your practice. What you'd like to do is a modular approach. So you'd like to mix and match the best in breed for what you want to do. So if you want a certain imaging system, you don't want your EHR vendor to tell you you have to use some other system. If you buy an office, if you combine offices over distance and they all have different imaging systems, you want one to be able to talk to the other, to display the images consistently and persistently with the same diagnostic information. So boiling this down, think about usability, functionality, and interoperability. A lot of things we're going to talk about will relate to that. So remember that one slide. I'm sure it's etched in your head. Who are the stakeholders in this? So we heard earlier from our speaker from DentaQuest, and I don't think she's here right now, but she said she might have to cut out. So anyway, I'm sure she'll watch this on tape. She'll watch the rerun. Maybe she's TiVoing it. Anyway, these are the stakeholders, and certainly there are a lot more than this. And notice that patients are stakeholders. Patients own their data. They need access to it. They should be able to accumulate it. Now, let's keep it real, okay? Probably don't even remember the Dave Chappelle show, but this is the Keeping It Real segment from the Dave Chappelle show. Well, if more people remember that, it's more recent. Okay. This kid comes into your office. He's allergic to penicillin. To what extent, we don't know. How quickly will you know? You need to treat this child right now. Not related to me, okay? But this is I credit Mark Deal for giving me this slide, a colleague. So here you see Axiom. This is the medical record we implemented, medical history we implemented at Maryland. So I was working at University of Maryland, and we went fully digital at a remote clinic we opened about 50 miles north of Baltimore, near the Susquehanna River. It's called Perryville, home of a casino. But we made Perryville, according to the mayor, a university town. We had students come up there 3 weeks in their senior year. They lived at a beautiful carriage house from a mansion, 8 meals in the mansion. They liked that. It was a DuPont, gave that to the dental school. So it was very nice, right on a bluff overlooking the Susquehanna. At any rate, we went fully digital from the time it opened. We made this intuitive, and it was, I think, a big success and a big hit. There's another way to do this. This is the VA dental record, which is actually integrated completely with what's called VA's CPRS, Computer Patient Record System. And in this case, the dental is launched as a module off the tools bar. So you see the tools bar, and then you click on Dental Record Manager Plus, and it opens the dental record. Regardless of whether you're running as a standalone application in your dental office, your one-person dental office, whether you're in a group practice, whether you work in a number of group practices as an associate, whether you're in an institution, or whether you're already in an integrated system like the VA, your dental information needs to be bidirectionally interoperable with the medical record, so whether it's a standalone or not. So as the dental record is part of the overall patient electronic health record, so we must be able to communicate bidirectionally with the medical side of the house. And you see that when you go to the OR, I'm sure. If you go to the OR, do they have Axiom in your OR?
Yes.
Okay, very good. And do they have a separate medical record?
The medical record of the hospital is separate.
Yeah.
The Axiom,
So it would be nice if that was aggregated. For instance, you could, so if in the VA record, you'd see the patient's problem list, medications, all their orders, all their tests, all their results reporting, and that kind of thing. So a problem list and so forth. So ultimately, that's where we'd like to be with dental. So I'm going to just show you a few quick examples here of what some of these different records look like for entry and symbolism. It's not standardized. We're standardized on completed care because we have CDT coding, and we have certain data elements we turn in with those transactions. That's why payers can look at claims data and know that it's one field, the D code is equivalent to another D code, and that's not saying it was entered correctly and it's documented correctly, but at least in the claim, you have a discrete data element you can compare. But on the findings and the conditions side, no. So we're all over the place in dentistry, and we're doing some things in standards to help remove that. This is an example of how you can display data. The progress notes in Axiom that we set up were not auto-generated. That was a coming feature in Axiom, and it was just too complicated. We were trying to keep it simple. And when they said it to me, they said, keep it simple, stupid, because you can tell why. So at any rate, this is the VA record. In this case, that periodontal data that was generated in VA could also be displayed as a table. So in the middle of this, actually, you know what? Okay, I can't use the mouse here. But anyway, so this is the same data that would be entered in a charting format, displayed as a table. Now in Axiom, Axiom is a set of tools that can be configured in many ways. This is how we configured it there, and we had different colors corresponding to different conditions and what was on the different screens. This is a nice feature in the VA record where you can click on any tooth, combination of teeth, or click on all for things that were performed but not related to teeth. You get a reverse chronological summary of what was done, either based on a tooth or you can get it based on a current episode of care, which had definitions of what a current episode of care was, and you closed it out. All episodes of care or episodes in a date range. So you could set this for anything in the record, and you could look at an entire history of what had been performed on tooth 14, for instance. So another display of using color and Axiom. There's all kinds of work going on right now. What are safety alerts in records? How should information be displayed so it's a good user interface? If you're interested, you should pursue that as far as informatics because it is very interesting and timely. This is we had a head and neck lesion tracker in the VA system, VA record. You could resolve the conditions. Now, this is what I want to point out, caution. All of these systems get very difficult to get a composite picture of the patient at this point in time because of display limitations or display algorithms. So for instance, if you look at this tooth, and I don't know if you can read this, but this tooth, number 4, which is what this one is, has a DO composite that's completed and existing. It also has caries. So when you look at and it has caries on the lingual. So this tooth has a 5, has a DO composite, and it's defective, and you've done a composite. So as time goes on, if this becomes defective again or you add another cusp, it gets very difficult to see what the current situation is. So just be aware of that in your display. It's pretty good when you go through the first episode of care, but as you add subsequent episodes, it gets very confusing. You really have to look at the transactions most of the time to figure out what was done. You can't get a composite picture. So imaging might help with that. So just be aware of that. Now let's talk a little about imaging. Intraoral images, also known as endoscopy in the imaging world, medical imaging world, are valuable. Of course, you want your radiographic package. In this case, this is Plan Mecca. Do you have, what imaging package do you have here? Okay. That's commonly used with Axiom, not in my packs. So, but anyway, we at University of Maryland, we were a Romexis school. So Plan Mecca software is what we used for the imaging, not for the electronic health record. And we had an interface with that. This is an example of Plan Mecca Romexis, Plan Mecca Promax 3D using their software to manipulate the image. There are specialty modules, and sometimes what's in a specialty module, they do duplicate entry in institutional settings, so ortho may note caries in a certain place in their record, but it's not in Axiom, and it should be in the same place, and it should be actually aggregated across the patient's complete treatment history. So if a general dentist sends you a patient, and then that patient's going to go back, they need to know in their electronic record what's been done, and you need to see what they were referring in with and what you differed on. There's also patient education, which could be in the module, or it can be at the point of care or remotely over internet. So the patient goes home, and the father brings the patient in for an ortho consult or a pediatric consult, and then when they go back and mom comes home from work, mom says, "What'd the dentist say?" And dad goes, I don't know. I'm not really sure. So they can go on and look at a prepared set of modules or films to figure out what's going on. Digital dental devices, software, devices, and equipment. Let's look at these. We have cameras, extraoral cameras, various types. We have various intraoral cameras. We have microscopes. We have CCD type sensors. We have various big assortment of those. Some of those might be out of business. We have phosphor plates. A lot of schools like phosphor plates. Do you use those? Phosphor plates, yeah. Pediatricians and schools like these because it doesn't interfere with the workflow much. You don't get an instantaneous, but you know these things last a while, a number of uses before they get scratched. And if you accidentally put one in the sterilizer, the heat sterilizer, it doesn't cost you thousands of dollars. So anyway, I hope you have 3D imaging. Do you have 3D imaging here? Which one do you have, Cone Beam? Okay. Well, this is the old ICAT and the new ICAT. Plan Mecca has one. There are a lot of them out there now. Then you have medical modeling. I'm just going through these to give you a flavor of what we're talking about in the real world. Remember, keep it real. So this is some computer-guided CAD-CAM type of information. digital surface scanning, so digital impressions. You can make digital models. Here's the CERAC that can use various ceramic and or resin blocks. Now this slide is an example of what you can show your patient for before and after, or current and promised. Be very careful what you promised. I always thought this was cool because if you look at the upper left, you see the dancing teeth, how the diastema closes. I thought that was kind of cool. And likewise on the upper right, you get rid of all that PFM. If you can deliver that with occlusal clearance and it does look good as promised, you'll be golden. If it's not, you've got a problem. Patients' expectations are very high. So digital dental devices, basically, don't think of them as hardware anymore. Really, hardware in the dental office is mostly controlled by software now. Now, admittedly, a hand instrument, probably not controlled by software, but ultrasonic or any other kind of scaler is controlled electronically. It's got firmware at least in it. Handpieces now are controlled by software. Electric handpieces are controlled by software, and even some air turbines have a hybrid model now. Midwest has one where it's got some characteristics of an electric handpiece and some characteristics of air turbine. So remember that hardware as well as software is regulated as medical equipment. And then the FDA is going beyond discussing this. They're implementing some regulations. And they come in from the standpoint of safety, not necessarily efficacy. So we look at beyond safety when we look at standards and requirements from an ADA perspective and from a profession delivering care perspective. Remember, security and privacy are obviously issues. You know the difference. Security is you can't get it, and privacy is even if you get it, you shouldn't be able to look at it. It only goes to who needs to see it. And so anyway. Now, you ask yourself this question: is an iPad or a Kindle a medical device? Because if it's displaying information that you're using for clinical decisions or you're looking at images on this, it is. I recently went to a DICOM, Digital Imaging and Communications in Medicine, meeting in India, and it was a good give and take between a developing country and people coming from more developed areas as to what they do. So for instance, they had a radiologist from Yale, trained in United States, now practicing in India, but also licensed in the United States, who does remote reads from emergency rooms in the US. There was another gentleman there, same scenario. He does intensive care monitoring in the evening in rural hospitals that can't have an intensivist there all night. Done in India, he's licensed in the US. There were people from Sweden that have their radiology reads done. There was the country, this is from a national perspective, at a reading center in Barcelona corresponding to the daylight in Sweden, and the daylight in Barcelona, and then in Sydney, Australia, when it was nighttime in Sweden, and the people in Barcelona were asleep. So this is possible. Now, the gentleman from India that does ER reads, does them on an iPad, and he said he can do them on an iPhone. And he said the only one they can't read, so like if you have someone that has a stroke, a CVA, and you want to know is it a bleed or is it a clot? And of course it depends on treatment, it's an urgent type of thing. He can read that anywhere, anytime, on any device he feels, accurately, adequately, and he does it. And he said the literature has proven that it's accurate, diagnostic yield is accurate on that. Now, so their big mantra was turnaround time, minutes can mean a difference, anytime, anywhere, any device. He said the only thing they can't read on an iPad right now are mammograms. And he said mammograms, they may be able to read them on the iPad retinal display. It would be medical grade. They're investigating that now. So we're having a tremendous drive from developing countries who have a need that aren't as regulated as the developed countries like the United States that are regulated by the FDA that need to do things right now that make a difference, and they do them. So we have a lot to learn. It's a two-way street on learning this, and that's why DICOM goes to developing areas for their conferences. So what is our goal here? Real-world functionality, usability, and interoperability. How does the ADA support that? And so the ADA is a recognized leader in standards activities nationally and internationally. And this is for the informatics perspective as well as the products. So we have the ADA CDI. Anyone who wants to get involved, you're welcome to volunteer and become a player, so to speak. You can come in around one project that matches your subject matter expertise. You don't have to make a lifetime commitment to standards. You can come in and out based on your expertise. We have an infrastructure running to help you do that. All of these standards are developed. There are two types of standards. There are industry standards like CDT codes, current dental terminology codes for payment. They're not an industry, they are an industry standard. They're not developed through a voluntary consensus process. Most standards we use are developed through an accredited voluntary consensus process. That, in the case of the U.S., is administered by the American National Standards Institute, or ANSI. So we're accredited by ANSI as a standards development organization, and that is a rather rigorous process, but the ADA is. Now, the ADA also has liaisons with other organizations. I mentioned DICOM. That's for imaging exchange, persistence, and interoperability, so that you get a persistent, secure exchange, and the person reading it seeing the same thing you're seeing, so you can do the same diagnosis. We do HL7, Health Level 7. Think of HL7 more in terms of messaging, and they're getting a little bit into the functions of an overall EHR, and we're partnering with them to do the dental side. Our ADA Standards Committee just came out with a standard that was published on the functions of the EHR. So we also have architectural issues, architectural standards rather. And we do the International Standards Organization. It's actually ISO, but since it's French, it's in English, it's International Organization for Standardization. Anybody speak French? What would the here? So the equivalent, it comes out ISO instead of iOS. Is that correct? Yeah, thank you. I'm glad an actual French-speaking person verified that. So we have those, the technical committee, global SDO for organized, and the global SDO is a voluntary consensus group, but it's organized by member nations having a vote. In some countries, standards have the power of regulation and legislation. So in the US, we use ASCII, American Standards Committee, X12 transactions for HIPAA. The Portability and Accountability Act has, okay, I have 5 minutes, good. We're going to go fast then. The Portability and Accountability Act, also known as the Clearinghouse Support Act, because a lot of companies make you use a clearinghouse instead of putting it in a format that could go point to point without the clearinghouse. Eventually that will change. And then we have these vocabularies, the SNOMED and SNODENT. So these are diagnostic vocabularies used for clinical conditions and problems. They are going to be built into the ONC, Office of National Coordinator, meaningful use criteria as we move forward in different stages. And we have a subset of SNOMED dental concepts called SNODENT. The ADA runs the dental special interest group with this international group. And then they review for all over the world the dental concepts, and then they boil them down to a usable vocabulary in the US, or usable terminology set. That's under validation testing now also. So you want to find out more, go to the ada.org site, standards section. So we talked about CDT. Those of you who work, which you do probably, use medical codes, CPT. I talked about SNOMED already. Now, the other coding is ICD. So if you submit a CPT, a medical code claim, you must accompany it with an ICD code, International Classification of Disease, which is maintained by WHO. So you probably are already familiar with that. If you're not, maybe you're using counterforms and your coding department in the hospital does it. So in this case, what we're trying to say here is, what is semantic interoperability? It's an assurance that it's a more complicated and precise way of saying, I tell you something and you understand it the same way I mean it. So we have semantic interoperability. So you get it and I get it, basically. Now, codes may be selected behind the scenes, and so Margarita Fontana, my eminent Caries, queen of Caries, I would say, queen of Caries management systems, she was talking about this. There are a lot of ways to classify caries. I'm not an expert. I'm a clinician in this. I'm a general dentist. Right now we do tooth and service for claims. There are a whole bunch of other ways to do it, which you can read and you're aware of, I'm sure. What we need to move to is, let's classify what we see as a finding independent of treatment. The ADA has 3 levels: enamel, limited to enamel, clinically and radiographically; moderate, enamel is not clinically broken down, but there is radiographic or clinical evidence of caries; and then we have severe. So you look in, you see a big hole, or you see a lot of breakdown on the radiograph. You can also do site definitions. I'm not going to get into the particulars of this right now. I wanted to show you that there is a backup for this in the coding. So these concepts are represented in SNOMED and SNODENT coding now, so you can use them. Now, SNODENT IDs that you see in the first column, just for those of you who are ever going to use this or be aware of it, we're eliminating the SNODENT alphanumeric IDs and going just to SNOMED numeric identifiers. So it's an extra step that will be cut out. You'll still see the same concept, and you use it clinically the same way, but it'll be behind the scenes. It will be changed. This is how they're put in, one way they can be put in Axiom. Implementation and certification. Office of National Coordinator, Meaningful Use. CCHIT, of which I'm on the board, is one of the groups that can accredit a record or certify a record for meaningful use payments. Meaningful use payments come out through CMS via the states. Integrating the Healthcare Enterprise is a standards-based, sort of a downstream standards development organization. They take base standards like DICOM, HL7, and they combine them in ways that will work in the real world that are demonstrated at what are called connect-a-thons. The first dental connect-a-thon will be occurring in January of 2014 in Chicago with a follow-up demonstration in 2014 in New Orleans at the ADA annual session. So these implementation and certification activities apply to all of these areas. I would say just note, somebody mentioned teledentistry earlier and remote consultation and remote monitoring. They are going to grow. Data aggregation is going to be a large issue moving forward. And personal health records is a term you haven't heard recently, but the patient owns their data and should be able to aggregate it and view it the same way that you do as a provider. Hopefully yours is aggregated. For more information, you can go to this website. Look at the product list. These are ONC sites. This is the CMS site for getting the meaningful use payment. I'm going to give a little plug to CCH, a little shout out here to CCHIT and IHE if you want to check them out. So they'll be in the handout. Let's talk, we're almost finished. Let's talk about outcomes, quality measures. So as the speaker from DentaQuest mentioned, keeping score does change behavior. Even keeping score changes behavior. Now, it might not change it the way you want, but it changes it. Dentists certainly look at production values at the end of the day. If you look at performance indicators, performance measures, quality indicators, quality measures, and ultimately quality assurance, most quality assurance needs to be done with a little more in-depth look at the patient. You can look at certain indicators that may be a certain number of standard deviations or an outlier from what you'd expect, a red flag, it could be good or bad. The ADA Dental Quality Alliance is looking at e-measures that are based on very precise things like CDT codes reported and so on to look at quality, what the Dental Quality Alliance calls quality measures. And then finally, accountable care. So there are ACOs and there's the CCHIT, Health Information Technology Framework for Accountable Care. So the Quality Alliance is looking at those initial measures you see on the right. I encourage you to go to the website for a more detailed look. And there is the website again. So it's got a whole bunch of information if you're interested in quality measures from the Dental Quality Alliance perspective, about 30 groups that the ADA is convening but not leading. It's independent. They're also doing validation testing through grants. Here's the Health Information Technology Framework for Accountable Care. For any of those who want more detail, you can get this on the internet, and it's got a whole framework. You may not use every aspect of this framework, but some aspects will apply. It's actually a pretty good overview. So those are some of the pages from that. Once again, there's where you go on the CCHIT website to get that. There's also on the Health Affairs blog, which is a journal. There's Karen Bell, who's the chair of the CCHIT Commission. She used to work for ONC, and she's from Massachusetts. Now, there's Ray Lewis. Okay, so in case you don't know it, the Ravens won the Super Bowl. They last won it 12 years ago. We're all very happy, and it brought back memories coming to New York. First of all, again, sort of a cute picture thing here. These are two of my grandsons at the Giants-Ravens game this year, which the Ravens was the only game all year they crushed anyone. They crushed the Giants, as they did in Super Bowl 35. However, we have not forgotten that in 1969, the Jets, probably you don't remember this, they upset the Colts 16-9. It was a heartbreaker. Anyway, we have a long rivalry, Baltimore with New York. In '69, we lost basketball, baseball, and football championships to New York teams. Wasn't a good year. At any rate, now I'm in Chicago. So Chicago. And so that's another picture. That's my daughter, and that redhead you saw, that's her last year. And my son-in-law, who's a big baseball fan, he's an Orioles fan, but he's got the Cubs hat. He had to go to Wrigley Field on Easter Sunday and go to a game while my daughter and I took the baby home. Anyway, once lacrosse is over, however, in the spring, we now in Chicago we have another sport. So the Hawks, as they say, the Black Hawks are playing for the Stanley Cup. They play tonight at 8 o'clock Eastern if you want to watch it. They beat the Bruins, another city we like to hate from Baltimore, the Orioles against the Red Sox. We love to hate them, and the Patriots. Anyway, they're playing tonight at 8, so it's the Bruins versus the Hawks. I'm for the Hawks in that one. So anyway, thank you very much. I would encourage you, if you have any reason or desire to contact me about any of this stuff, I will be more than happy to discuss it. Don't get me started on this. It's very interesting, actually. I would encourage you to do good. So do good, but also do well. So just remember, when you're making some decisions on where you're going to practice, you have to make sure you're taken care of. You have to do well for your investment, but do good also. I think the two aren't mutually exclusive. So thank you very much, and I will be happy to entertain any questions.
Greg, one of the things we talked about yesterday that I know is of direct interest to pediatric dental trainees around the country is the use of information technology by consumers so that the relationship between consumers and providers is changing. Some thoughts about that?
Yes, it is. We're getting into much larger areas of joint decision-making, and joint decision-making based on their data and based on, hopefully, refereed information from other sources like internet. So the more you can provide good links to resources to help patients make these joint decisions with you, the better off you'll be. As I alluded to in the home care, when the father, who did I say brings the patient in? The father brings the patient in, the mother's getting home from work and wants to know what happened. And in this case, let's even complicate it more. Mom's paying the bills. Dad's a stay-at-home dad. So Mr. Mom, so to speak. So at any rate, yes. And the other thing I did not mention is as far as big data. So let me just throw something out here. Big data. And I used to say, probably never saw The Graduate. So there's a movie called The Graduate, okay? And in The Graduate, he's like disillusioned. What am I going to do? He's graduating. He's at a party his parents are having at the house, and this guy comes up to him and says, I got one word to say to you. Plastics. Right, plastics. Well, now I think the word would be analytics. Go into analytics. So you've got analytics. From analytics, you can do data mining. You can do predictive modeling. And you can get into big data. Big data is not necessarily about cause and effect. Big data is about correlation. They can predict a flu outbreak from sales in stores better than CDC can with their epidemic outbreak notification system they devised. And they are looking at, like Harley Davidson looks at how tight every screw is tightened up on the motorcycle. There was just an article in the Wall Street Journal the other day that GE invested $2 billion, some of which was big data for healthcare. So they're investing $2 billion in this as a private company. They also have like 700 or 800 people working at a center in Bangalore, India, so as do IBM and Philips. So at any rate, yes, big data.
And one last question that came up yesterday is about whether there's such a thing as the private, independent, localized dentist anymore, or whether the person who thinks they're working that way is really, because of large servers in the cloud, part of a network that they may not even be aware of.
Well, I think, yes, they certainly are part of a network that they may not be aware of. For a lot of ways, data can be aggregated. But I think the key in thinking of this is we are networked. That networking is going to grow. Real-time supplying of data and ownership of data is going to grow. So we should be active in determining how that happens. And if you ever buy a practice that has a digital system that you don't like, and you try to import that data right now, you are going to have a major problem and a major expense and a lot of manual work. And I'm talking about even with imaging. So Dentrix got out of the imaging business, and they went with DEXIS. Importing the Dentrix imaging into DEXIS was basically a manual transformation or manual importing. You do not want to do that when you have hundreds of thousands of records. You just need to be aware. In fact, when we had a Council on Dental Practice review of why informatics was important. One of the things they said was that even older dentists, older than myself, for instance, but older dentists that have been around for a while need to take technology into account, because the younger dentists are demanding an updated technology solution when they buy the practice. And some patients come in and say, do you have digital imaging? Well, no, I don't. Well, I'm not coming to you anymore, because I understand digital imaging is 50% or more or less radiation exposure to me, and I'm concerned about that. One other comment, the Intersocietal Accreditation Commission, IAC, is doing Advanced Dental System Imaging Accreditation for dentistry. Right now, that applies to all facilities that submit to Medicare. California and Minnesota have made it a requirement in general to get paid by third-party payers. That's going to be a large issue, that dentistry cannot stay isolated from the mainstream and say, we do CBCT and we do it in our office and we don't want anyone telling us what to do. It's not going to happen anymore. You're networked in, and you've got to be part of that medical network. So I really thank you for the opportunity to be here, and you've been good sports about me sort of rubbing it in your, getting in your face about New York sports teams. I'm going to leave immediately afterwards because I don't want you to have a chance to do it back. Thank you very much.
Thank you.